Welcome back, everyone. I am Dr. Khan, and I am absolutely pumped for today's session. We're diving into the world of skeletal development, specifically focusing on what happens when the foundation of the body literally softens. We're talking about rickets.
And I'm Dr. Sarah. While Dr. Khan brings the energy, I'll be keeping us on track with the high-yield facts you need for your boards. Rickets isn't just a historical footnote. It is a critical clinical diagnosis involving defective mineralization of the cartilage matrix in growing bones.
Think of it like this: building a house. Normally, you set up your wooden frame and then pour solid concrete to lock it all in. In rickets, you've got the frame, but your concrete never sets. It stays wet. So when the roof goes on, or in a child's case when they start walking, the whole structure starts to buckle. Sarah, give us the precise academic breakdown of that wet concrete phase.
Exactly. From a physiological standpoint, rickets occurs at the epiphyseal plate, the growth plate. In a healthy child, the cartilaginous matrix should mineralize into hard bone. In rickets, that mineralization fails. The cartilage cells actually continue to grow and proliferate, but because they don't calcify, you end up with an excess of disorganized soft cartilage. This leads to a characteristic widening of the epiphyseal plates on an X-ray, which is a classic board exam question.
See, that's huge. Why does this matter clinically? Because if you're a pediatrician and you see a toddler whose wrists look unusually thick or knobby, you aren't just looking at baby fat. You're looking at that widened, unmineralized cartilage literally bulging out because it can't support the mechanical stress of the child's movements.
And that mechanical stress is where we see the most famous signs. Since the bones are soft, a condition we call osteomalacia in adults, but rickets in children due to the involvement of the growth plates, the long bones of the lower limbs will begin to bow. This is genu varum. On the boards, they love to pair the clinical image of bowed legs with the underlying cause, vitamin D deficiency or calcium malabsorption.
It's like trying to walk on stilts made of licorice. But it's not just the legs, right? I always tell my students to look at the chest. Have you ever heard of the ricketic rosary?
A high-yield favorite. The ricketic rosary refers to the enlargement of the costochondral junctions. These are the spots where the ribs meet the sternal cartilage. Because of that same defective mineralization, these junctions expand, creating a string of visible beads under the skin of the chest.
It's such a striking clinical visual. And don't forget the frontal bossing of the skull. The forehead becomes unusually prominent because the bones of the vault are soft and expand under the pressure of the developing brain. Why does this matter clinically? Because these deformities can become permanent if we don't intervene early. You want to be the doctor of choice for these families, which means catching these signs during a routine physical before the child develops pelvic deformities that could cause issues later in life.
That's a great point about being the doctor of choice. Precision in diagnosis is key. For the exams, you must distinguish rickets from osteoporosis. Osteoporosis is a loss of total bone mass. The structure is fine, there's just less of it. Rickets is a mineralization defect. The structure is there, but it's not hard. Dr. Khan, how do you explain the difference in the laboratory findings for these?
I use the quality versus quantity analogy. Osteoporosis is a quantity problem, fewer bricks in the wall. Rickets is a quality problem. The bricks are made of sponges. Clinically, in rickets, you're going to see low serum calcium, low phosphate, and typically high alkaline phosphatase because the osteoblasts are working overtime trying to fix a problem they can't solve without minerals.
Perfect. And remember, students, the most common cause globally is vitamin D deficiency. Without vitamin D, the gut cannot effectively absorb the calcium and phosphate needed to harden that cartilage matrix. If you see a clinical vignette with a child who is exclusively breastfed without vitamin D supplementation and has delayed walking, your rickets alarm should be screaming.
It really is a perfect storm of anatomy and biochemistry. You have the endochondral ossification process we read about in the chapter, but it's interrupted at the most critical stage. The body is trying to grow, but it's lacking the glue to hold it together. Why does this matter clinically? Because treatment is often as simple as supplementation and sunlight, but the impact of missing it is a lifetime of skeletal struggle.
To wrap up the high-yield points, rickets is a disease of the growing skeleton. Look for widened epiphyseal plates on X-ray, ricketic rosary on the ribs, and bowed legs. It's a failure of cartilage matrix mineralization, not a lack of cartilage itself. And my clinical takeaway? Always palpate those joints and look at the gait. If the concrete isn't setting, you'll see the building start to lean. Great session today, Sarah. Agreed. See you all in the next chapter.